Welcome to the Medical Manners Podcast, where I give healthcare providers simple tips for ways they can transform the way they connect with their patients and colleagues. Connecting with patients isn't some secret sauce that some of us have and others don't. They're just skills, implemented consistently over time. If you want to transform your medical practice, you're in the right place. I am Katie Wyatt, your host. This episode is sponsored by the Connect Better audio course. This course is for healthcare providers who want to drastically improve their patient satisfaction or Press Ganey scores. Each week for 6 weeks, you will listen to a 5 to 10 minute audio training. Then throughout the week, your job is to implement the skills you're taught in every patient encounter. You'll be amazed at how much your score can improve in such a short amount of time. Go to medicalmanners.com and use the code PODCAST for 10% off the course. Today, I have Hannah Belnap with me on the podcast. Hannah, I'm so grateful for you and for your willingness to take time to come chat with me about this. Hannah and I knew each other, I don't know, what would you say? We knew of each other. We've known of each other for a couple years, but have just kind of reconnected recently over the idea of the frequent flyer patient. And so Hannah brings some really great perspective that I'm excited to talk about. So Hannah, why don't you introduce yourself? Tell us about your career as a physician's assistant. Maybe start there.
Sure. Happy to be here. Good to see you again. I have been a PA for about 16 years and started out in an inner city clinic doing mostly internal medicine in Chicago, and then moved to Utah, spent some time doing family medicine, and then back to internal medicine for a while. And the last 3 years, I have actually been doing palliative care. It's been amazing. I do home visits now instead of clinic, and I love that for a lot of reasons, not least of which one we're about to get into, which is my chronic migraine. So this job has made it a lot more doable to still practice medicine, and it's also kind of brought to light some of the stuff we're going to talk about too in terms of frequent flyer patients who have frequent need to visit the ER or be hospitalized. And so, yeah, that's where I'm at right now. About 3 years into palliative care, mostly home-based home visits.
Yeah, and that's a great segue into your headaches. So how many years have you been struggling with headaches?
Yeah, started when I was about 20, so about 20 years ago. And for most of that time, up until 2 years ago, I took, triptans and got through life. I tried, maybe 5 or 6 years ago, I started trying preventative, saw a neurologist. They've always been fairly bad, several a month. But about 2 years ago, I started to have them probably more days than not, 15 to 20 migraines a month. So I get the Botox protocol, and then I tried sort of all the new fancy medicines that came out, the CRPs, and everything really that I could think of and that my headache specialist clinic could think of. And about 6 months ago, it got to a point where I had I don't know if you want me to step right into this, but I had my first emergency room visit ever in 20 years of migraines. And that was last summer. And that was definitely eye-opening, but I was treated very well. I had to I'd been getting multiple IVs. So sorry, I'm jumping around a little bit. Over the last 2 years, it got bad enough that I didn't want to overuse my triptans. And so I would have to get IVs from my headache clinic, which fortunately I was able to manage, a Monday through Friday. I didn't need an ER visit until last summer. During the course of that, I sort of worked out through those IVs what worked for me, what didn't. As you probably know, a lot of the migraine cocktails include things like prochlorperazine or similar promethazine, similar medicines. And I became super sensitized. I don't know what kind of brain I had, but it became very sensitized to all these medicines. And I would get the dyskinesias, which are absolutely terrible, where you just jerk your whole body. And even tizanidine and sort of more mild muscle relaxants started giving me dyskinesias. So by last summer, I was really, other than getting the Botox protocol and taking my triptans, I was really kind of out of options. And that landed me at the ER. And I was treated well, but I did have to the reason I tell you that about dyskinesias and the muscle relaxants is that was the first time I really had to use a benzodiazepine in that ED visit, they gave me some lorazepam because my whole muscle, my whole body was spasmed, and migraines give you neck spasms, and neck spasms give you migraines, etc. And they gave me a dose of lorazepam, and it broke it, and it helped me, essentially knocked me out so that I could sleep it off, broke it with the muscle tension. So that's kind of where I was at up until last summer. And then I had a ED visit in August, my first one. And then about a month later, I had another one in September. By October, I realized, along with my headache specialist, that I'm in medication overuse. And it happened, just innocently. I switched to nasal triptans, which are faster onset, so higher risk of rebound. And I just realized I was kind of using 3 or 4 a week, and sometimes more, probably cheating. And here I was. So by October, I was in a bad spot because nothing worked anymore. My triptans not only gave me a severe headache 24 to 48 hours later, but actually stopped working. And that's when I did a lot of research into, we call it either medication overuse headache, or the more, I guess, recent correct term is MAH, medication adaptation headache, which I like better. It's a little less judged. And so that in late October of last year is when I started my journey of the trip detox. The reason that is relevant is you really have no choice but to just suffer through until they get out of your system.
Whole turkey. You just stop.
And what I also learned now, here I am a few months later, I'm like 80 days sober from triptans at this point.
Congratulations.
Thank you. It is a big thing. What I have since learned is the newer medicines like the triptans that the CGRP molecule, they didn't work for me at all for the last 2 years. I'm like, why don't these work for me? Why don't these work for me? What I've since learned is that chronic triptan use elevates your CGRP levels, and until you detox for like 60 days or more, those levels go down, and suddenly now these medicines work. So now I'm in a point where they work for me, which is great, but that's only as of the last 3 weeks.
Okay.
So essentially from, October, November, December, I was in just the dark age. Nothing working, suffering through. I took a leave of absence from work so that my entire job was to have migraines.
Yeah.
Was to be in a dark room with ice pack. I was absent from my life.
Yeah.
A lot of it is a blur. I honestly don't even think that trauma is too strong of a word for what it is to go through that and to feel so helpless, to think, wow, in 20 years, I've never just let a migraine go. What a privilege, I guess. I've never had to unmedicate, let it go. But that's sort of the background on what my migraine journey has been, if that helps.
Yes, that is so helpful. And I think this is a good time to go into the bad ED experience that you had. Tell us about that. And knowing your backstory, I think, is super important. And actually, one thing we'll talk about later, but I think often when we don't understand our patients, it's because we don't know enough of their story. And so I think it's so helpful having that backstory and now kind of going into this experience that you had. So yeah, take it away. Tell us about that.
Okay. So again, I had the ED visit in August, and then I had one in September, and then I had one in October. I was on like a once a month schedule, which again, in 20 years of having migraines, never having to do this, it was, humbling to say the least. So in October, I had my third visit, and they were all really pretty good. Like everybody I felt like was really good to me. They got me in quickly, and they all seemed really grateful that so remember, even though these were just I'd only had these 3 ED visits, I'd had multiple IVs, and it's kind of a cocktail that they give at my headache office.
So you knew what worked and you knew what didn't work at this point.
I knew what worked, what didn't work. I knew what made me really worse, right? Like the prochlorperazine is such a common part of the migraine cocktail, and that's just a no-go for me. Same with metoclopramide. And so I felt like these first 3 ED visits were great. I felt like people were just like, oh, I'm so sorry you're here. And oh, that's so great. You're a PA. That's so great that you know what you need, like pen and paper. Tell us what you need. And by this point, I was like, I need this dose. I need this medicine. I need, magnesium, Benadryl, whatever. I also think it bears mentioning that these are not controlled substances. apart from the one dose of benzos that I had, the lorazepam dose I had in August, these are generally migraine cocktails are things like anhydramine and magnesium, and then just fluids, 2 liters of fluids, really. That fluid bolus seems to be, but at least for
Important.
me.
Yeah.
So I'm not coming in asking for narcotics or wanting them.
You're not the IV Dilaudid girl. Because I've worked in the ER and they're, like I need my IV Dilaudid. We have those. So, but you're saying this was not it. You were not asking for narcotics or benzos, really.
No.
Okay.
Nope. And in fact, narcotics make me worse. So I always walk in there clearly saying, I know I'm writhing in pain. Please, no narcotics. So I had these first 3 visits, but in October, it was towards the end or middle of October, I had this visit. And then that's when I started my detox, my cold turkey. So a week later, I find myself, having just been in the ED a week ago, I find myself after hours, of course, so I can't go to my headache clinic, having on hour 24 of just an out of body experience, most unimaginable pain. I always in those moments think if I could you're so irrational. I think if I could actually pop my eyeball out, like maybe pop my eyeball out, like deflate the pressure. And if I don't pop my eyeball out, it's probably going to pop out itself. Like that is what it's like.
Yeah.
And it's also, I always explain to people too, like until you've had a migraine, it's not a headache. It is a full body experience. You are dizzy, you are nauseous, your entire body is inflamed. I mean, it is like, and afterwards you have this post-ictal state, like so you have this post-stroke for like 24 to 40. So I'm on hour 24, having just been to the ED a week ago. And my first thought, my husband is sitting there, in tears, thinking, it's so hard to watch. And he's like, let's go. And I keep saying, no, I was just there a week ago. It's like, I can't because I would be a frequent flyer. That's so embarrassing. I can't. And so by about midnight, when I was like literally screaming in pain, like think like Lamaze breathing, labor, like pacing, holding my head, he like gathered me into the car and gets me over there. And he's half carrying me through the parking lot. And the whole time in this like most exquisite pain of my life, I am still so powerful as this association in my mind that I'm saying to him, mumbling to him, I'm a frequent flyer. This is embarrassing. I'm a frequent.
Yes.
This is so embarrassing. And that experience, so this is, now my 4th visit in 3 months and my one being just a week earlier. That experience was markedly different than the other 3. And and part of it is just factors that's luck of the draw, right? It was busier that night, the different providers you get, whatever. But they only had the triage room for me. So first I had to wait for, I don't even know how long, an hour or more, which I know in ER terms isn't even that bad, an hour or more in the waiting room, fluorescent lights, shoving my face into like the hard edge of the chair, just, and breathing and trying to not look like a complete psychopath and humiliated. And they finally get me back and they only have the triage room. And what I remember, again, so much of this is like almost dissociated. It was so sort of intense. But what I remember is that I was in a chair, not a bed, because they only had the triage room. And I remember shaking so violently that like the foot plate on the chair was really loud, like rattling. And I was like rocking and couldn't stop. And I sat in there for a long time. And this time, I would say the biggest difference is when the physician finally came in, a few things. One thing I remember is thinking, nobody seems to have a sense of urgency. Like the nurse comes in and slowly clicks around and like, I'm thinking, get IV access, like, please,
Yeah.
I need these medicines. And then the physician comes in and says, hey, yeah, so sounds like you got a headache. And I said, yep, it's my typical headache. I've had MRIs done. There's no red flag symptoms with this, whatever. And she said, are you sure? Because you've been here a lot. And it was just the way she said it. And granted, me being in this incredibly vulnerable place. And I just said, I know, I'm so embarrassed. I said, I'm doing a detox. I can't take any of my triptans. This is where I'm at. So it's, I'm probably going to need more IVs during this time. And she kind of clicks through like, okay, what do they usually give you? And so I said, what they usually give me. And I said, also, my very first time back in August, they gave me a dose of lorazepam. And I think that will really help me tonight because now it's like midnight and I'm spasmed. Who knows what time, middle of the night.
Yeah.
And she just didn't answer me. And that was embarrassing. Sitting there at this point, I think I'm like actually pacing and she's just clicking away, kind of like as if she's bored, clicking away at the computer and doesn't answer me. And I said, so, she clicks, is just kind of quiet. And then she just goes to leave. And again, I'm feeling like I don't want to be a pest, so embarrassed. And also like, I'm clearly bugging you. And I'm already in this sort of apologetic place. And she goes to leave. And I say, could you tell me what dose you're getting? And she just kind of stops in the doorway and turns back and says, we're just going to try Benadryl first. And she leaves. And I, long story short, I end up, getting the IV. A couple hours goes by. And I think from a patient's perspective, again, like me being on the other side of the bed, which so often we aren't as healthcare providers.
Yeah.
I think to recognize that like every time somebody walks out of that door, you're not going to see somebody again for a long time.
For a while. Yeah.
And how vulnerable that feels. And so to know like, okay, I now have to invest another hour shaking so violently that the foot plate's rattling and like, retching an out of body experience. And you're just going to try Benadryl. And by the time 2 or 3 hours goes by, I was not any better. And I finally, like one more time, super embarrassed, said, do you think we can try lorazepam? She said that if the Benadryl didn't work. And I remember the nurse being annoyed, sort of giving a little sigh and saying, I can ask her. And she came in eventually and gave me like a quarter dose. So bottom line, I ended up just leaving and I had an emergency dose of clonazepam at home that my neurologist had prescribed to me to be able to just sedate myself. And I, by 3 a.m. sedated myself and got through it. It wasn't until almost a few days later that I really processed sort of this experience and generally just the whole different tone and how I think the overriding feelings for me were vulnerability and then shame.
Yeah.
And I kept thinking, you have no reason to be feel ashamed, right? Like, you're asking for one dose. I wasn't asking for a prescription. You could check my Doppel. I think I had filled 3 lorazepam in the last 6 months, for these emergency doses or clonazepam. But I just thought a lot about it as a healthcare provider and sort of all the different steps along the way, the little things that probably to that doctor and that nurse seemed like nothing. They weren't overtly rude, but I think when just recognizing what it feels like to feel so helpless and vulnerable for the patient, I guess. And anyway, we can expound on that more, but those are kind of the facts of how it went down.
Yeah. Well, and I was thinking just that initial sentence that she said, where she said, are you sure? Because you've been here a lot. And I thought she could actually have said the same thing in a different way and had it not been a big deal. Like if she had said, Hannah, it looks like you've been here a couple times for headaches. Tell me what's been going on. It seems like this is really affecting your life.
Yep.
Right? Like she could have gotten the same answer. And her idea was, you have been here quite a bit for headaches lately. But I think even just instead of saying it in that way, like, are you sure you're not lying to me because you've been in the ER a lot? That phrase versus, it looks like this has really been affecting your life lately. Tell me more about this. That's night and day.
Night and
difference, day. Right?
Right. And which is a perfect segue, I think, into what happened to me a week later. And so I go to my headache clinic and there's 3 different locations of this headache clinic. And this was a location I'd never been to, people I'd never met. But I walked in there and they can see in my record how much I've been there. And I also said, I also was in the ER a week ago. And the MA was this young girl and she almost got tears in her eyes and she grabbed my hand and she said, oh my gosh, I am so sorry. You've needed so many IV. And that is exactly what you're saying. It's the same way of saying, wow, you're needing this a lot. But like, in this, I'm so sorry. Right. And so immediately that's the tone. And then she goes to the computer and starts doing her workflow. And she says, I know you're hurting, and I want to just make sure I've got your medicines. I'm going to do this the quickest way possible. And she's like, let me streamline this. And she, click, click, click through the meds. And then she says, the other way I think it'll be faster is if we have, XYZ come start the IV. Then I'll get the nurse practitioner in here. And she was like, what else? Like, let's do this. This is, we're urgent.
Yeah.
And at this point, and I'm shaking. Migraines make your whole body shake. And she says, why don't I get you a heated blanket? Do you like those, or do those make it worse? Brings me a heated blanket. And we both look over at my poor husband, who's like always the collateral damage. And he just has tears running down his face. I'm getting emotional talking about it. And he just said, what's your name again? And then once I had the IV started, he kind of snuck out and went to a store and bought some chocolates or treats or something with a note. And I don't actually know exactly what he said in the note, but I know it was something to the effect of, your kindness today means a lot more than I think you'll ever realize, And it was the same thing with the nurse practitioner. She came in really quickly and then checked on me. And just the language of it was so different.
Yeah.
And yes, I want to totally acknowledge that a clinic is not the same as the ED. And I, God bless those people that work in EDs. And I've never done it other than a rotation. And so I want to acknowledge all that. But anyway, I just think it highlights, I think, some important things we can talk about.
Yeah, for sure. And I agree with you. I try to be really hesitant about being like critical of decisions that healthcare providers made, because we don't know what the 10 patients before you in the ER were that night. We don't know all the backstory. We don't know that, but I do think we can learn moving forward. And I think we can learn and try to do better ourselves. Yeah. And I'm even thinking back about that, when you ask for the lorazepam and the doctor kind of gave you the look, right? Even if she would have said, I typically try other medications before I go to benzodiazepines. Tell me the doses of all the medicines that typically help you that aren't controlled substances. Let's get those on board as quick as we can, and let's reevaluate in an hour. Like even if you're hesitant about jumping to the benzos, that's fine. We've been taught to be cautious with those.
Yep.
Even that would have been a totally different experience for you, instead of like, we're just doing the Benadryl and leave the room, right?
And the fact too, and the fact that that she just kind of ignored me, and she was ready to just walk out of the room and not even tell me like what was going in my body. And I stopped her and asked, and it made me reflect on the position I've been in so many times, and so have you, and so have all healthcare providers, when someone's asking for controlled substances. And it made me reflect on, I think when I was really young in my career and I was really intimidated maybe and wasn't as like bold or assertive, I think that I wanted to avoid the confrontation and probably didn't handle it great. But as I've learned and matured in my career, I really try to, even if someone is blatantly drug seeking with all the red flags, I really try to just directly, assertively kind of address it in the moment and just say like, whether it's like, what, this is outside the scope of primary care, this number of narcotics. And let's talk about some options that might be better long-term, sustainable, feasible, like answer them and talk to them like they're a human. It felt really dehumanizing to be ignored and to have to be like, sorry to be a bother, like as you're walking out of the room, but like, if I could just ask what you're going to give me,
what you're going to put in my veins. Yeah, for sure.
I think that we're all legitimately worried about people abusing controlled substances for so legitimate
good reason. Yeah.
There is no question about the statistics and what's going on in our. And I just think that like one thing is be really careful about painting people with broad strokes. So like, I get the being conservative, I get the being worried, but let's look at the individual. And so in my example, let's look at my Doppel report. Let's look at like, I have been in the ED multiple times and received one specifically didn't want it the other time, like earlier in the day, et cetera. Like, I think number one was controlled substances, just being so careful about not being with broad strokes and looking at the individual. And if there are red flags, I just think, how can we set sort of compassionate boundaries that aren't humanizing? How can we use language that isn't dehumanizing? Even now in palliative care, I obviously do a ton of pain management with cancer patients that above and beyond that I never did with in primary care, fentanyl patches and liquid morphine concentrate and all kinds of
Mm-hmm.
that I never did in primary care. But even then, there's certain patients that aren't appropriate for me to manage home-based palliative that need a clinic that can do drug screening. Even then, even if someone has cancer, it doesn't mean that there aren't things like diverting meds to family members or et cetera.
Yeah.
And so I thought about, like, okay, how, even when they're, first of all, not painting someone with broad strokes, look at the individual situation. Second, when there are legitimate red flags, how can I do better as a provider at the way I handle that? And I've tried to use again, directly addressing it, not ignoring,
Yeah.
and try to use things like, I'm not set up, whether it's primary care, palliative care, whatever. I'm not set up to do this in a way to keep you safe. But what I would say to my patients is, but I am going to find you a sustainable place that is.
Yeah.
Like my job, the buck stops here. And so here's some pain management options. Here's some clinics. Here's my guy that does celiac plexus blocks. Here's,
Mm-hmm.
and so I think still saying, like, I care about your pain. I care about your experience. Here's how we have to keep you safe. It's not going to work for me to do it, but I'm going to make sure you've got a safe landing place before I send you off. And that, I think, goes over so much better than sort of like, yeah, I'm not doing it. And but,
For sure. Well, right now I do telehealth and I do telehealth urgent care. And so I had a patient call in who ran out of her sleeping medicine, and it was same thing, kind of like a Friday afternoon. She didn't know if she needed it on her trip, but she was afraid she wouldn't be able to sleep on her trip, and I looked and she hadn't been abusing it. Her numbers looked good. I can't do that kind of stuff on telehealth. We don't do any controlled substances, which is super nice. But she had tried calling the doctor's office, and they had said that her doctor was out of the office till Tuesday. And so I just called the doctor's office for her. And I said, hey, this is the situation. It's a patient of who's out of town. Are there any other providers in the office that could see her this afternoon, just so she has this through the weekend? Guess what? They got her right in. Yeah. And I didn't help the patient. I couldn't help the patient. But it was not hard to just kind of help guide, just like you're saying, guide the patient to where might be an appropriate place to have their needs met or to talk about those needs. So that reminded me, even if I can't help them, I can still help them.
Huge help. And also, I think you illustrated to that patient that I care about beyond a policy. Like, you totally could have easily just leaned on, hey, our telehealth policy.
We don't do that. Yeah.
And to say, but wait, you're a human. It's a Friday. I wonder what tonight will be like for you. I wonder what your weekend will be like for you. I wonder if you have to work. I wonder if you're a mother. I wonder, right? And so I think we communicate to the patients that we see them still as a human, and sort of a little more empathy,
Yeah, for sure. So in the course that I teach, I have an empathy formula that I teach providers, because some providers are super good at it naturally. Like, if you say to someone, I need you to show more empathy, they're like, got it. I know what to do. But there is a whole group of people out there that you could say, I need you to show more empathy. And they literally, that doesn't mean anything. They don't know what to do. And so the definition of empathy that I got my formula from is, empathy is the ability to understand and share the emotions of another. And so, let's say with this lady who saw me who wanted sleeping medicine. I've never taken sleeping medicine. I've never really had a tough time sleeping. So I can't naturally empathize with her, because I've never been through that. But the two parts of the formula are show that you understand and that you're willing to share that emotion. So I can understand that emotion by saying, I have had nights with sleepless babies that I have not slept. And you feel really crappy the next day. You're dysfunctional. So she's going on a trip. If she has a night where she doesn't sleep, that takes out that whole next day of that trip for her. I can understand that. And I can tell her that I understand that. And then I can show her that I'm willing to share her emotion by helping her do something about it. Like, okay, I understand. Let me help you get to this person who can help you.
Yes.
And so I think it really helps providers that aren't naturally empathetic to have that formula. Like, okay, I have to show them I understand. And then I have to show them I'm willing to share that emotion. And if you check those two boxes, ma'am, the patient feels empathy.
It goes so far. The other thing I will say too is I think I am somebody who has natural empathy, sometimes too much. It can be hard to live in a world where you have a big empathy button. And so I do think that, I look even at just the last 3 years of my palliative care experience. And my first, couple months or even 6 months, I was constantly, my husband's like, I don't think you can do this job. Like, you're coming home bawling every day. And these, people are dying.
Mm-hmm.
People are dying. People are terminally ill every day compared to like the prior 13 years in primary care where I'm managing like cholesterol and what's interesting is you adapt. And I think it's necessary. I can't, come home crying every day from work. I think it's necessary. But what happens, I've noticed is it is easy, and I'm sure this is even more so in an ED, is you just get used to it and to not feel it anymore necessarily. Especially my older patients. Like if I still get like a 30-year-old diagnosed with terminal cancer, that still gets me in the gut. But sometimes when I have a 90-year-old, it's easy for me just, clinically trying to triage and think through like, oh, okay, yeah, we won't do these treatments, or they don't need these extensive interventions, et cetera, et cetera. Yeah. So one thing that I do for myself when I'm noticing that I'm not connecting or feeling it is I try to make it personal. I try to say, hey, but Hannah, remember, for example, your grandma. She was 93 when she died, but she meant everything to you. And her death was super hard. And someone else might look at that and be like, she was 93. Like, and I'm not saying her death was a tragedy, but I wanted to carefully navigate those last years of her life and her healthcare options because she was my grandma. Yeah. And she was a big person in my life, And I think that reaching, like you said, if you have a hard time, you don't have a hard time sleeping, you probably know somebody that does, or you've had a bad night with your babies or whatever. And so I do think that everybody, if we can make it just a little bit personal and, find some connection, that's been a tool I've used too for that, getting that sort of like attenuation of empathy response that happens over time,
Yeah, for sure. I think it's a big life skill in our patients, but also like with my husband, with my children.
Mm-hmm.
I think we should have this like tattooed on our foreheads. If you are getting bugged by someone, you don't know enough of their story.
Yeah.
So if a patient is bugging you, and we all have it, we all get bugged by patients, whether it's because they're frequent flyers or whether it's 1,000 other reasons we get bugged. And in those moments, I try to tell myself, recognize the emotion. I am feeling bugged. What do I do when I'm feeling bugged? I try to find out more of their story. So I'm like, tell me what these headaches, how these have been affecting your life. Tell me what it's been like. And even though I'm bugged, when I start hearing someone's story, it makes that instant connection. Or with my kid having a hard day, right? Instead of just being like bugged, there being a nightmare. Tell me tell me some of your story. And that changes everything.
It does. One of the lines we use in palliative care a lot, just to bring it down to specifics like that, it's like, obviously you have cancer. Obviously that's a big deal. Obviously like your metastatic bone pain hurts, etc. But one of the lines that we use a lot is, what's the hardest thing about this day to day?
And a good question.
It's such a good question. And it brings it down to like, what is your day like? What is the hard thing? And anyway, I think that asking that question is important for a couple of reasons. It brings it to it brings it to the specific. And I also think I remember being told in PA school years and years ago that the most important thing to you as a provider isn't always the most important thing to a patient. And so they might come in and you're like, okay, your cholesterol's through the roof, or your blood pressure is terrible, right? And like, I got to fix this. Mm-hmm. And they're like, I've had this rash that's driving me crazy and keeping me up at night. And I think until they feel heard, until you ask them, like, what's the hardest thing for you? It's going in one ear and out the other, managing their blood pressure. They're like, and you're like, I know your shingles hurts, but like, that's going to get better. That's not going to give you a stroke. Right. And they're like, no, my shingles is what I care about, So I think we're, what's the hardest thing about it, bringing it personal, and then also, remembering the most important thing to me isn't the most important thing to them always.
Yes. Oh, I love that. That is so good. Okay, one other just idea I wanted to talk about it because in the business world, right? The business world thrives on frequent flyers. I
Mm-hmm.
mean, we give people airline free flights who fly frequently, right?
Right.
We give points at a grocery store where every single business model is like, how can we get this person on a subscription so that they're coming back frequently? And so it's so interesting. And I think it's the only place I can think of that we're bugged at frequent flyers, that we're bugged that they're coming back for more
Yep.
help. And
Yep.
I'm trying to figure out why that is. They literally are the people that keep our numbers up and give us
Yeah.
and our job security. And so I'm trying to think of why we get bugged. I don't know. Do you have any insight on that?
I have a theory, at least for me, and this may not be everything. Probably most people in healthcare really want to fix things. And when it works, so I'm thinking of a patient just this week, super advanced dementia with agitation and very, very difficult paranoid behaviors, not even livable at all for the family. And I, prescribed sort of standard of care medication for dementia agitation, palliative care type stuff, things like haloperidol, more terminal type
Right.
dementia treatments. And I didn't, with this particular patient, her partner wrote me back and said, "This has changed my life. You've saved us." And just gushing to me. "You've saved our lives. This has been amazing. 1 milliliter of haloperidol, and she's no side effects, and she's not tired. She's not sleepy from it, but she's just calm and she's pleasant. And I was able to even go to the doctor." And my gut reaction, of course, is like, I feel so good. Like, yay, I did such a good job. I did such a good job.
Mhm.
But in reality, I've applied that same standard of care to so many patients, and half the time it doesn't work.
Mhm.
Half the time they don't respond to it, or half the time it works, but the side effects are intolerable. And so, back to why do we get bugged? I think for me, if I'm going to take the credit when it works really well, that also means that when it doesn't, I'm going to take it personal. I'm going to feel I think I'm going to feel frustrated. And if I look inward, it's really because, dang it, like I wanted to fix you, and I'm taking this personally. It didn't work. And I think that if I can step back and say, this isn't about me. And so if I can even use language like, even when it goes well, language like, I'm so glad this medication worked for you.
Mm.
Not I'm some amazing sorcerer that just is the most amazing provider that fixed you, as much as, great, you won the biochemical lottery and this medication worked for you.
Right.
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 And it's kind of the same with parenting, right? Like, kids come out of, I'm going to take credit for my kids that are just easy peasy great kids. That means I also got to own the ones that are difficult. When
Yes.
like, it's not about me. And so I think that for me, I sometimes get bugged because I'm taking it personally that it didn't work. And I even have sensed that with some of my headache doctors, because I have been so refractory. I have been the worst of the worst, to quote one of my headache specialists. And the things that they're so excited to say, oh my gosh, look at all this migraine innovation. We got these CGRPs. No, we're going to really help you. And for me to show up and say, sorry,
Help.
it didn't.
Yeah.
I've sensed even annoyance. And I don't think they're annoyed at me.
Yeah.
If you really ask them, I think they're just like, dang it, this has been so fulfilling and fun for me to like have a tool for my migraine patients. I'm like, no, you're supposed to respond. And I don't know if that makes sense, but for me, that's, I think, where a lot of it comes from is I'm bugged because it's, dang it. And
Yeah.
it's supposed to work. And sometimes people are just refractory, and maybe I'm taking it too personal. Maybe I'm owning too much of it. I'm taking too much credit, for better and for worse.
Totally. Totally. And maybe it's like, wow, okay, that didn't work for her. I literally don't know what to do next. I'm a headache specialist. We have tried everything. So it may even be taking it personally, but also admitting that I don't know what else to do for you.
Mm-hmm.
And I think we do go into medicine because we like to help and we like to fix and we like to heal. And so it may even be a pride issue, like,
Yes.
I can't fix this.
Yeah.
Nothing I've done has worked. So I think you're spot on with that. And actually, you know my dad, Hannah.
Yeah.
My dad often says, I have siblings that have done really great things and siblings that have done stupid things, right? We all have. But people always say to my dad, oh, this kid is so great. You should be so proud. And my dad, literally, I've heard him say this so many times. Oh, I don't take credit when they do the good stuff because I don't want to take credit when they do stupid stuff. He says that all the time. And so I couldn't agree with you more there. I think you're spot on.
Yep. And I think if we can address that issue, not make ourselves feel like a failure or the patient feel like a failure. Not my headache specialist's fault that I didn't respond to these exciting, innovative new drugs. And it's also not my fault.
Right.
And if we can just get down on a person-to-person level and brainstorm and be like, wow, we've really got to think outside the box. And me especially, I mean, I literally work in the number one specialty probably where we're set up to see.
You're not going to fix it.
We're not going to fix it. And we're set up to see people who are being hospitalized all the time. And I go into visit and I actually count their hospital stays in the last 12 months. That's a prognostic indicator, right? And so how can I show up to their homes and say, you've got advanced heart failure. You've been hospitalized 6 times in 12 months. And I'm telling you that because it's a prognostic indicator. How can I say it in language that isn't like the ER doctor to me? You've been here, you know? And I think that we can just watch our language and not make them feel like a failure. And sometimes I do and sometimes I don't, because I've seen patients react to me and almost start apologizing. Like, I know, I just don't know what else I'm supposed to do. And then I realize, like, okay, that came out wrong.
Yeah.
They're apologizing to me that they've been in the hospital, And so I think if we can frame it as what I've tried to say in those situations is, you've had an incredibly difficult year.
Yeah.
Wow, 6 times in the hospital. I cannot imagine how exhausting and difficult.
Yeah.
Right?
I love that. Love it.
So what I'm here to do is talk about big picture. Where are we going with it? How can we help with, and I just think that's over a lot better.
So much better. So much better. And it actually helps with patient outcomes.
Yes.
Even though you may do the same treatment, when you show up with compassion and with empathy, study after study shows that patients' outcomes are better. And so even if you can't do this just because it's the right thing to do, which it is, it's the right thing to do to treat people humanely, right? Mm-hmm. But even if you can't do that, you will have better patient outcomes.
Yes.
Your patients will respond to therapy better if you show up with compassion.
The hospital utilization rates will go down.
Yeah. Well, Hannah, I think it's been so good for me to hear this from you as someone who's seen both sides of that. You're a healthcare provider. You get bugged at the frequent flyers. You were a frequent flyer. I think that is I'm going to think about a lot of things you talked about today for a long time.
The unique thing about being a healthcare provider who then has to become the patient is, not only do you know a lot about your condition, but you also know the medicine and how to navigate that. And then extending that out to just even patients who aren't healthcare providers who have dealt with something for a really long time and know more about their conditions sometimes than you do. And I think how to navigate taking care of other healthcare providers and taking care of patients who know more about their condition on some levels than you do.
Right.
And I think that the humility sort of required there. Just because I think of those multiple ER visits or my multiple visits to the headache clinic where they got out pen and paper and said, what's worked for you?
Yeah. Yeah.
And I think that if we as providers can put pride aside, and whether it's some of my patients have really obscure illnesses that I'm like, I actually really don't know that much about, ALS or, things that you don't necessarily see all the time. And I think putting the pride on the shelf and saying, first of all, what's helped you before?
Yeah.
Even with simple things like SSRIs, like, oh, you didn't respond well to fluoxetine, whatever. What's helped you before? And then I also think saying, even when we're just trying to figure it out, saying, you're the one living this day to day. And this is what I say to patients and families all the time. You're here every day. What do you think? So, for example, I saw a patient yesterday who has interstitial lung disease, one of the most common sort of terminal lung things that I see, and you can't do anything for it. Essentially your lung tissue is being replaced by scar tissue. And a lot of times by the time they come to me, they've got air hunger, which we treat with low dose opioids. And I'm so used to doing that and applying that formula when I got this. You're an interstitial lung disease patient. You're telling me that you're feeling short of breath. This must be air hunger. But the more I sort of explained that, and here's what air hunger is, and given my whole speech, I could like read the room. And like the patient was kind of like shaking his head, and the family's like, I don't think that's it. And so if I was like, what do you guys think? Is this not landing? Does this not resonate? And they said, no, because it really seems to only happen when he's nervous about something. And so the more I talked, I'm like, you know what? Like the more I really asked some questions and got their thoughts on what did they think about my theory, the more I was like, you know what? Yeah, actually, these are more anxiety. This is more just anxiety, not really related to air hunger. And they're like, he breathes in through his nose and that really helps. I'm like, right, of course, because it is oxygen. Or breathing slowly through your nose also helps when you're feeling panicky.
Oh, right.
And so I think being able to, maybe we go in with a theory because we think it's we know what it is and we see this all the time. And being able to pause and say, does that feel right to you? You're the one living this every day.
Yeah.
Like, does that seem like what's going on? Or even saying, what do you think's causing it? Or what do you think it's associated with?
Yes.
And sometimes they look at you and go, I don't know, you're the doctor.
Yeah.
But a lot of times they look at you and say, here's what I really think,
Yeah. I think that is so crucial. And it's something I try to do with every patient. I'll kind of say, okay, this is what I'm thinking. What do you think? How do you feel about the plan? Always, always. And it's so funny. Some of the times I get bugged most, it's when a patient comes to see me with a note from their chiropractor. Their chiropractor will have written down what the patient needs.
Yeah.
Why does that bug me so bad? Probably because I'm prideful. But I'm like, the chiropractor can't prescribe. Okay. Right. I can prescribe. And I'll kind of like get up on my like tower where I'm like, they don't know. I know. I'm the one who's gone through the schooling. I'm the one who's done this. And I think you hit it spot on with pride and just that ability to step back and say, this chiropractor sees lots of patients with the same issue. He gets lots of feedback on what has worked for patients. That doesn't mean I have to do what the chiropractor said, but I should look at that paper and I should see. And if it's a treatment that is safe, that I'm comfortable with,
yes,
why not? Why not? If it's worked for others in the same situation and I feel like it is an evidence-based safe practice, why would I not? And so I do think it's that ability to just step back and say, whether it's the chiropractor that's telling me what to do, or whether it's the patient that's telling me what to do, it really doesn't matter if I can just step back and say, okay, what is it? Is it safe? Am I comfortable with it? If so, sure. Why not?
Totally, because I think we have to acknowledge that, everything that I said, as nice as that sounds, ask for the patient input, etc. The other sort of opposing, very true thing is that we are trained professionals. We're not like vending machines. We're not, or as one of the docs I used to work with would say, it's not Burger King. Right. You don't come in here and order what you want and we just dispense it, right? And so that's also true. And so just because a patient or a chiropractor or whoever comes in and says, hey, this is what I think, we're not just following orders.
Okay. Right.
Right. And that's true. And so I think it's just being able, like you said, to balance that reality and say, I'm going to bring my expertise and my opinions, but just it's how you frame it, right? It's if we can say, I hear you. Here's what I've seen with some of my patients. So here's what I wonder. And sort of balance, because both of those things are true, right?
Yes.
We're not fools.
Yes.
But also input is valuable, from all sources. And be able to balance that and look at, I guess, our motives. And I also think navigate when we maybe make recommendations to other providers, like you did with your telehealth patient and the sleeping medicine, being really respectful. A lot of times I have to email primary care providers and say, I think maybe this, or this is a possible thought, but I'll defer to you, and I think being able to frame it as, here's some ideas, but we're not. And I think that's why that ER visit was so hard for me, is because I am so hyper conscious that I was so apologetic about saying what medicines have worked for me, I was so hyper conscious of it that to then later read in my note, the clinical note she made with that visit, things like, patient is adamant about what she needs. And I'm like, I was not. I really, really wasn't.
Yeah. Yeah.
I was actually like obnoxiously apologetic, obnoxiously
Yes.
so sorry. And so anyway, not
Yes.
to belabor the point, but yeah, I think the language that we use in our notes, the language we use with other providers, and balancing that it's all true. We're professionals, and patients' perspectives matter. And sometimes the patient will think they know what's causing it, and sometimes they're right, and sometimes they're not. And but we're all. I think just this idea that we're on a team together and not try to not be patronizing.
Right. Patients will come in all the time, or I'll see them and they'll say, I Googled it and this is what I think I have.
Yeah.
And again, Dr. Google can make us bugged, right? That's a thing we get bugged at. But actually, it really doesn't bug me because I come from the viewpoint, I am so glad patients are doing their research.
Yeah.
I am so glad they're involved in their health and that they're part of it. And a lot of times they're right with the research and a lot of times they're wrong. And I just take that as an opportunity to be like, based off of my experience and my training, this is why I don't think it's what you found online.
Yeah.
And I tell my patients often, I never say never. I really don't. I never say never. But if I was going to make a list of things that I think are causing your problem, that would probably be on the bottom end.
Yes.
Because of this, this, and this. And patients always take that super well.
Yeah, it's hard. It's a lot to navigate. It's a lot to navigate. Some patients are difficult. Some patients are abusers. And also, like, I'm coming from this place of palliative care where I see 3 or 4 patients a day in their living rooms. Far cry from, an ER shift. And so I think it's a lot to navigate. And I think that, all we can do is make small steps in ourselves, the language we use, am I taking this personally, looking in the mirror,
Right. Hannah, what is the name? I send these podcast episodes to specific providers or organizations that are doing a great job. I send them an email thanking them and I send them a copy of the podcast. So do you mind sharing the awesome headache clinic that you go to?
Yeah.
I'm going to reach out to them.
Yeah. So I go to, it's called Foothill Family Clinic. It's run by Dr. Henry, who is kind of the guru in Utah for migraines.
Say the name again. What was the first name?
Dr. Dan Henry.
Dan Henry. Okay.
He has 3 locations. This particular one that I went, they've all been excellent. Every time I'm seeing all of their prayers, I've been to all 3 locations. But this particular incident was in their Draper location with Emma. And and I'm bad with names. So the fact that will never forget both the provider and the MA were both named Emma.
Wow. Okay.
Yeah. They were, I don't know if they fully understand what those little kind words, just the smallest words meant in the context of the picture. So yeah.
Right.
But it's
awesome.
Anyone suffering with migraines that is where to go to get, I think, the best of it. So
awesome. Cool. Well, I will reach out to them. Kudos to them. Sounds like they're doing an awesome job.
They are. Yes.
So awesome. Well, thank you, Hannah. I appreciate your time and I hope your headaches, it sounds like you're on the uphill and you're getting to a good spot. So I'm so happy for you.
Yes. That's another episode in and of itself. Yeah. The medication and migraines, all of that. But absolutely. Kudos to you for all you're doing. What a cool thing.
Yeah, thank you. It's been fun. It has been so rewarding just to hear the good that goes on. I think there is so much good. And so I've loved interviewing patients and providers and hearing all the good. And I hope we can all elevate each other together, just be a little bit better. So
yeah, it's not for the faint of heart, practicing medicine, and especially in the culture of the country and the medical culture, it's hard, right? So again, I just want to say we can all just be maybe a little bit better, but kudos to anybody that's doing the hard work.
Thanks for listening. If you enjoyed today's episode, the best way to support what I do is by rating and reviewing the podcast. Your feedback helps me reach more listeners to make an even greater impact. It would also mean the world to me if you would share it with a friend or colleague who you think could benefit from the topics we discussed. Together, we can transform the way we deliver healthcare by transforming the way we connect. Take care.